Okay, it's 7 a.m. So we can start. Dr. Kruer, I will let you start your presentation. Thank you very much for being here.
Thanks so much, Kara. And good morning, everyone. I think I know most of you, but for any who don't know me, I'm Michael Kruer. I'm a pediatric movement disorders specialist here at Phoenix Children's. And I had the pleasure of talking to you guys last year about the Phoenix Children's deep brain stimulation program, which is still modest in size compared to most adult pediatric deep brain stimulation programs. But it's a really, I think, nicely integrated multidisciplinary program here at Phoenix Children's, and it has grown to be one of the largest pediatric DBS programs in the country. This morning, I'm going to be talking to you also about DBS, but more on representing the neuroscience research that's happening here at Phoenix Children's. And I'm going to be talking to you guys about some of the recent updates in pediatric DBS, and in particular focusing on the potential role of something called local field potentials in pediatric DBS. When Jay gave one of his first talks here last year, he talked about how presenting grand rounds through Zoom is kind of like shouting into the Pacific Ocean, and that stuck with me ever since. But I say that just to emphasize that we're all friends here. I'd like to make this as interactive as possible. If anything I say is unclear as I go or questions arise, you don't necessarily have to wait until the end. Please feel free to ask those as I go. So in terms of this particular talk, here are my disclosures. And really, they just have to, they relate back to some of the support we've gotten for the pediatric DBS program and some of the work that I'm going to show to you this morning, which has been funded by the Phoenix Children's Innovation Circle. And we've also gotten educational grant support for our pediatric movement disorders program from Medtronic. But in terms of the learning objectives for this morning, really there are two. And I really want to spend the time focusing on some of the gaps that currently exist right now about using deep brain stimulation for children and adolescents with childhood movement disorders. And then I'd like to also focus on potential ways that local field potential information can help to inform treatment decisions for patients that are either undergoing DBS therapy or are candidates for it. And so really, just to start at the 30,000-foot view, I'm going to be talking about pediatric movement disorders. And fundamentally, these are brain network disorders. We've long thought about these as lesions in the basal ganglia, but we now know that other areas of the brain, including primary motor cortex, supplementary areas of the cerebellum and really subcortical regions can all be involved. And that these are essentially brain circuit disorders or brain network disorders. We know that the pediatric movement disorders can sometimes be, relatively mild and almost incidental as part of a broader neurological and neurodevelopmental syndrome. But we also know that sometimes they can be the primary presenting complaint, can be painful. They can certainly be functionally disabling, affecting the way that kids dealing with these walk, talk, eat, use their hands, etc. And they can be socially distressing. And we know that they affect thousands of kids in the US alone. As far as today's talk, I'm going to focus on dystonia and chorea. And so just to start with a couple of brief definitions. So dystonia is something that you hear me talk about a fair amount, but at its core, dystonia, I like to think of it as a movement disorder that distorts patterns of muscle activation. And that distortion of normal muscle activation leads to, at times, non-velocity dependent hypertonia, differentiating it from spasticity, and or recognizable postures. Now those features may lead to either sustained, that is sometimes called tonic, or intermittent, sometimes called phasic, abnormal movements, postures, or both. And we know that these movements and postures often will adopt familiar patterns. They can be repetitive, tremulous, and or jerky. We also know that dystonia can be initiated or worsened by different stimuli. And so they can be, dystonia can be triggered by sensation, simply, passively touching a patient as part of a physical examination, attempts at active movement or even passive movement of a limb. Certainly emotion. We have patients whose dystonia can be worsened by negative emotions, but also can be triggered by positive emotions, such as the joy they might have from watching their favorite movie or a sports game. And we know that dystonia, again, is typically patterned or twisting and maybe tremulous. Chorea, in contrast, really is similar in some ways to dystonia, but chorea fundamentally involves these ongoing random appearing sequences of discrete movements or movement fragments. And chorea appears much more random than dystonia. It also appears to be much more transient. And so I like to think of chorea as involving jumpy or jerky movements that kind of jump from body part to body part. And we also know that chorea in particular can involve negative phenomenology. So motor impersistence, or the inability to maintain a voluntary activation or posture, can sometimes be associated with chorea. And so as I talk about chorea today, I'm not going to talk so much about the specifics of each individual movement disorder, but for the purpose of today's presentation, going to be kind of, lumping chorea, athetosis, and ballism together. And so don't want to dwell on this, but just know that sometimes at different points, I'm a splitter. Today, I'm going to be a little bit more of a lumper when it comes to these movement disorders. And I'm talking about athetosis and ballism as part of the greater movement disorder spectrum with chorea. So what I do want to focus on this morning is the fact that we really have had this longstanding problem that movement disorders are a little bit of a black art in neurology, in the sense that a lot of times at conferences, people will present patients with complex movements to video rounds or panels of experts, and those experts, will often kind of highlight some of what they see are the important features for that crowd. One thing that can be quite challenging is that those experts don't always agree. And so I think that to some extent, movement disorders have been a little bit in the eye of the beholder. And importantly, there are efforts underway by several groups to try to objectively characterize movement disorders. But for the purposes of what we're going to discuss this morning, one of the challenges we face is that we can't see movement disorders very well with widely available techniques. So, for example, it's sometimes asked, how movement disorders and seizures are different. Well, for one, we can't see a movement disorder, quote unquote, with the surface EEG. Patients with severe dystonia will actually be largely EEG negative, except for potentially movement related artifact. We know that for patients with severe dystonia that can be completely disabling, related, for example, to DYT1, a classic cause of dystonia, their structural MRI can be completely normal. And we haven't had biomarkers of dystonia, and that's really been something that's been a challenge for the field. Now, I talked to you guys last year about deep brain stimulation and some of the positives associated with deep brain stimulation. We know that for the right patients, DBS can really be life-altering for kids with movement disorders. And just to quickly recap, we do know that DBS is a form of neuromodulation. It's something that's essentially thought to quiet abnormal network activity, going back to that concept of the movement disorders as network disorders. And we know that when it's effective, it can reduce the abnormal unwanted motor activations that we see in kids with movement disorders. And so here's a schematic of a little girl who has undergone DBS. And then to the right of that, you can see that this is the schematic of the DBS in situ within the brain itself, and how stimulation is anticipated to be occurring. But I think it's worth mentioning that still to this at this point in time, no one really knows exactly how DBS works. There are a number of proposed mechanisms that I'm not going to have time to go into today. But I hopefully will give you a little bit of evidence that DBS does perhaps work, at least in part, by modulating some of the abnormal network activity that's occurring between groups of neurons and within circuits. And so last year I was able to tell you some stories, and one of the stories I was able to share was of this young lady who was featured in some of our PCH literature. She's a young lady with DYT1 dystonia who was treated with DBS, and I'll show you some of her videos later in the talk. But she essentially was relying on a wheelchair when she first started to come to see us, and at the time of this story was climbing South Mountain with her family. And so DBS can be very successful for some patients. But what is extremely frustrating to me and my colleagues in the DBS clinic is that DBS does not work this well for every patient. And so one of the important questions is, well, why not? And I think that part of it is that not all dystonias are created equal. We know, for example, that patients with genetic dystonias tend to respond better than patients with acquired dystonias. But that doesn't necessarily mean that we say no to our patients with acquired dystonias. We just want to make sure that they have reasonable expectations for what DBS might be able to do for them. Even among genetic dystonias, one fact that is not necessarily well known is that not all genetic dystonias are created equal, and not all will respond well to DBS, at least historically. And we now think that part of that might be because some of these patients have periods of normal motor development. So some patients with dystonia will be relatively normal in terms of their physical development until age 4, age 8, age 14, for example. And we think that means that they have some of those intrinsic motor learning programs already successfully embedded within their brain to some extent that can be unlocked later, compared to kids that never have a period of normal motor development and experience dystonia from infancy, for example. We know that for patients with lesional forms of dystonia, lesions that we can see on an anatomic or structural MRI, we know that the deck is stacked against them a little bit, although this varies quite a bit depending upon the exact story. We know that the portion of time that the patients have dystonia can also impact their response. Certainly those that have developed long-term orthopedic complications, no DBS is going to take those away. And so we also think about responsive movement disorders as something that's part of the picture. And so residents and trainees that have rotated with us know that we spend a lot of time thinking about whether a patient has spasticity versus dystonia, for example. And this is something that in movement disorders neurology is quite important because at least at this point in time, we're not able to target spasticity through DBS. And I tell families that their child's spasticity is very unlikely to respond to GPI or globus pallidus based DBS stimulation. It just won't happen. So what I'd like to spend the majority of the time in this talk, though, discussing is this other idea, which is more controversial, but perhaps we aren't programming the devices the right way. And this sometimes causes a certain amount of indignation, but I'll go on record saying that, perhaps I'm not programming the devices optimally. And that's something that's led to some of the work that I'm going to talk to you about today, which really has been led by Dr. Preeta Bisarad, a very talented postdoc in my laboratory, as well as some of the collaborations I'll be telling you about. Now, just to kind of think about this a little bit deeper conceptually, it might not surprise you guys, but every brain is different. And so as we start to think about why DBS may work differently for patient A versus patient B, we, I think, can agree that one size does not always fit all. And when we're thinking indwelling direct current electrodes like a DBS, it turns out that the patients don't necessarily come with an instruction book. And so I think that this certainly factors into how we treat these patients and what responses these patients ultimately will demonstrate. And so when we think about DBS programming, one of the things that I'll talk quite a bit with families about is that, the surgery itself is tremendously important. And having expert surgeons like Dr. Houtman as part of our team who can really precisely target just the right brain regions is critically important. But even after that part is over, there's more than just flipping the device on. And so I like to think about DBS and DBS programming as being kind of like trying to make your way through a deep dark wood with only moonlight or maybe a dim lantern light to help guide you. And so it's something that I impress upon families, but that it really is a process to try to appropriately program the DBS for different patients, and even patients that have the exact same mutation in the exact same gene as the cause of their essentially similar movement disorder may require different stimulation. And so I use the deep dark wood analogy because I really have found that it's hard to know where you're going. It's hard to know when you've arrived at the right place. And by the right place, I mean the right stimulation parameters. And this historically has led to this kind of frustrating cycle of guess and check. Furthermore, we often find that with patients, there's a little bit of a Goldilocks effect. And so this is something I also talk with families about, before they ever commit to going through with DBS, is that we really do spend a lot of time trying to find the stimulation for a particular kid that is just right, not too much, not too little. And so by this point in time, the families are hearing deep dark woods, Goldilocks effect. I'll often talk a little bit about bubbles of electrical fields. And so we know that DBS represents a tremendously complex device. And I try to boil this down, take quite a bit of medical physics and pathophysiology, and bring it to patients and families, and hopefully with a somewhat digestible way. And I talk about how at the end of the day, we're trying to induce little bubbles of electrical field, of electrical stimulation. And we're trying to induce those bubbles in just the right place and just the right way for what that person, that child needs. And finally, what DBS is doing. Okay, and so at this point, families are often saying, "Okay, well, Kruer, come back down to reality." But no more fairy tales. But at the same time, I think that these concepts are important to introduce ahead of time for the family so that they know what to expect, particularly as they go through the programming, which I'm learning over the years is quite often individualized for each patient and can sometimes be complex. And so some of the things that we've learned from the literature, some of the things that we've learned in our own experience in the PCH DBS program, is that different patients really do need different bubbles. And again, this can be even patients with the exact same mutation in the exact same gene. And this was beautifully described in this paper by Michael Oken's group, which really talked about how that even for patients with DYT1, which is the classic responsive movement disorder or form of dystonia for DBS, the ideal candidate, if you will, these patients show variability in their responses, even though DYT1 is caused by a recurrent mutation. And this really speaks to the idea that there is a sweet spot that we're all after, and that sweet spot will vary from patient to patient. A second principle that we've recognized over time is that dystonia and chorea are tougher in some ways than the most common DBS indication in adults, which is adult onset Parkinson disease. For patients with Parkinson disease, for example, their tremor will often improve right in front of you with stimulation in the office. Whereas for patients that have dystonia, for example, we'll often see nothing right there in the office. So we might make changes to stimulation, but really it can be quite anticlimactic. The patients might be very excited about the programming visit, especially that first programming visit, and we might send them home with no appreciable change whatsoever in their movement disorder. Um, this can make it very hard to see where we are if we go back to that deep dark wood analogy. But this is something that has been recognized for more than a decade, and it's been found that electrophysiologic changes in deep brain stimulation, even things that can be detected through EMG, may change, but change over time and not be immediately noticeable. We've also seen more recently that other types of neurophysiologic changes can occur, but those are delayed as well, and more on that later. The third major obstacle that we face is that for patients with pediatric movement disorders, dystonia or chorea in particular, more of a good thing is not always a great thing. And by that, I mean that we've had this idea for some time that for patients with movement disorders, again, there is that sweet spot. And if we surpass that sweet spot, we can actually make their symptoms worse. We can induce movement disorders in some patients. I've actually treated patients, for example, for myoclonus, and by inadvertently overdoing or overstimulating those patients during an office visit, I induced dystonia. Well, that's obviously not what we want. And this has been written about in the literature as well, although it's something that largely has remained somewhat anecdotal in the movement disorders world. And so, for example, I've had some parents. I had a father of one of our patients in particular say, why are we just making a little bit of a change at each visit? Why don't we just crank it? I appreciated the sentiment. It was an important question to ask. But nevertheless, we've learned that just crank it is not necessarily the best way to program these devices. It's very easy to stray into overstimulation. And because we're trying to proceed carefully, if we stray off that path in that deep dark forest, it can be very hard to reorient ourselves as to where we should be. A fourth feature that can make things really difficult, and I only have five, so bear with me. But the fourth feature is that movement disorders can fluctuate, and this can make it hard to really assess responses. So we know that for a lot of patients with neurological disorders, they can have good days, they can have bad days. For patients with movement disorders, similar to patients with epilepsy, this can change even moment to moment. Now, for patients with movement disorders, we know that this can vary depending upon some of the afferent stimulation that they're experiencing or factors like emotion. So again, even being uncomfortable, having constipation act up for many of our patients, for example, or some of their muscle tightness, this can actually worsen their movement disorder. We know that sensory stimulation or even attempts at purposeful movement can worsen their movement disorder. And so when we're comparing how they're doing at one office visit versus another, there may be huge differences. And it could be related to something as seemingly innocuous as whether or not that patient is dealing with constipation. So this makes it quite challenging. Finally, the fifth feature I wanted to mention, or the fifth challenge, is that many pediatric movement disorders, as we all know, they occur in within the context of a broader neurodevelopmental or neurodegenerative condition. And so for many of these patients, speech or expressive language can be impacted. And if we think about it, patients with limited verbal ability may really struggle to express to us complex concepts or sensations. So a question is as seemingly straightforward as how do you feel may be quite difficult for them to answer. And so their parents are often trying to help us, and we're trying to watch for any indication of how they're feeling. but it can be challenging, to say the least. So, despite all these many challenges, I think that there is a light in the tunnel, so to speak, or light in the darkness, in the sense that there has been a major change recently within the last few years in the technology surrounding DBS. And so, one of these advances in technology is called local field potential sensing, and this really allows us to not only use the implanted neurostimulator in a particular patient's body to program from clinician to patient, but actually allows us to be able to, in a way, listen in to what's happening in their brain, but by using local field potential sensing, as I relate to families, to quote, read their brain waves during an office visit. And so what's been phenomenal about this particular technology is that once families have made the difficult decision to have a DBS placed, this can now be done non-invasively during a routine visit. And so essentially what this involves is the recording and the display on a handheld tablet programmer of local field potentials. And so local field potentials essentially involve the recording of the summed activity of many, many neurons, neural populations at once. And those summed signals will appear as an LFP. Those signals will undergo both high and low pass filtering and be displayed into time domain signals. And so they start to appear more like what you see here in the middle in the color. There's subsequently a process of binning and averaging all of this data. And really, this involves Welch's equation and what's called a fast Fourier transform. But many of the displays that we'll get as readouts ultimately look something like this power frequency plot that you see here in red on the far right. And so this essentially is a readout, if you will, of a certain amount of predefined time. For example, many times we obtain what's called a brain sense survey using the Medtronic devices. And this is something that we'll see over a period of 90 seconds what that patient's LFP activity looks like. And so I mentioned this very briefly during my last talk, but for example, if we think about, patients that have undergone deep brain stimulation with some of these newer devices, we're able to actually see the dystonia, and so in a new way. And so with this young lady, you'll notice that she has DOIT1, but interestingly, her dystonia is much more severe on the left side of her body. Well, you can see if we look at local field potential data that was collected during the time of this office visit, interestingly, she has much larger peaks in the right GPI, the right globus pallidus internus, that corresponds to that left side of the body. So there seems to be a difference even using one of her hemispheres as a quote disease control, if you will, from hemisphere to hemisphere. And this is work that we began with now our good collaborator, John Thompson at the University of Colorado Anschutz. What we've been able to learn over time is that we now see that for patients that undergo DBS, and if we compare the before, where she struggles quite a bit and is really relying on a wheelchair to travel any degree of distance, effective DBS leads to a remarkable improvement in the patient's ability to ambulate. If you compare before versus after Burke von Marsden scores, this is a reflection of the severity of the dystonia. She was a 64 to start with and a 3 at this point in time, having negligible dystonia. But what's also quite interesting is that if you look at her local field potentials, you can see that there's also quite a remarkable difference. Before, she has these quite significant peaks that are evident in the beta ranges of the frequency bands. And that although they haven't completely disappeared at the time of the second recording, this patient's local field potentials had certainly changed in appearance. And so this was one of the first observations that for us in our program gave us some clues that although perhaps this patient would have responded well to DBS in any case, perhaps local field potentials could give us some unique insights that we could then apply to help patients whose responses have been more challenging to optimize. And so as we set about really trying to collect and analyze DBS data, what I'm about to show you is largely Phoenix Children's collected data, but it's data that we've analyzed in collaboration with John Thompson and his team. And we've also started to collaborate with some of the largest pediatric DBS programs in the country to continue this work. But essentially, what I'm going to be showing you are data from three different recording paradigms. The first is what I just showed you, a brain sense survey. And a brain sense survey is collected with the stimulation briefly paused. The data is collected over roughly a 90-second epoch. And what you see is a power versus frequency plot capturing between 1 and 100 hertz. The capture is more or less continuous. And what that allows us to do is perform comparisons from clinic visit to clinic visit. So this is proven to be quite valuable in the right context. Now, in addition to the brain sense survey, which again is captured with stimulation paused, we have the ability to do what's called an active stream. And this can be done with the stimulation either on or off, but it's typically done right there in the clinic. And in the active streaming mode, we're able to define the duration ourselves. So in some instances, we've collected just over a minute of continuous data. In other instances, we've streamed with certain patients for more than 30 minutes. Now, obviously, we're very limited by clinic visit times, but nevertheless, for the right patients with the right challenges, this has been extremely valuable data. Finally, I'm going to show you some data from so-called timeline mode. And timeline really involves chronic sensing. And so with this particular setting, this is typically done with stimulation on, although it could be done with stimulation off. But chronic sensing allows us to perform long-term monitoring. So we enable this feature, then send the patients home. And the device will be continuously active, stimulating that particular patient's brain in the way that it's been programmed. But it will also intermittently sample their LFPs and record that data so that it can be downloaded at the next visit. Now, this is limited to selected frequencies of interest that we've chosen, but it can actually provide data over days to weeks, which has been quite powerful, and it allows us to perform long-term monitoring that's done with the patients in the wild, quote unquote. And so as we started to think about this, we started to wonder whether LFPs were more than just a curiosity and whether we actually might see consistent LFP features across patients with dystonia, despite the fact that our patients have all different etiologies of their dystonia. And so what follows is a series of unpublished preliminary data. We first looked at our dystonia patients, and this is from our first 12 patients in the series. And we asked the question, despite the fact that some of these patients had birth injuries, some of these patients had meconium aspiration, some of these patients had DYT1, some of them had completely different genetic etiologies. What do their local field potential spectra look like? And again, this was a plot of power versus frequency. And you can see that based on the individual tracings, there is quite a bit of inter-individual variation. But nevertheless, we started to see consistent patterns. And we started to see that in particular in the low beta frequency band, as well as in the high beta subdomain, we saw a relatively consistent peak across patients. And this was regardless of dystonia etiology. And so this was something that was quite fascinating to us. We then asked the question, well, what about the patients with primary chorea as their predominant movement disorder? And again, we simply collected this data from brain sense surveys. We looked at power versus frequency, and we had a smaller number of individuals. This was 5 individuals with predominant chorea. And what we found, nevertheless, was that there were some peaks that stood out, again in the largely in the beta range, but also extending into alpha frequencies, and perhaps distinct from those in dystonia. And so we started to ask the question, well, are the patients with dystonia and chorea really showing the same patterns? And so we then did an overlay and looked at the curves that resulted from the patients with dystonia in blue and the patients with chorea in green. And we found that, yes, there was quite a degree of overlap, but yes, there were also some distinct features. And this kind of matched what we were anecdotally observing as we would see each patient in the clinic. When we analyzed this through KS statistics to ask whether these curves were in fact statistically distinct, we found that in fact they were highly significantly distinct. And so we think that we're essentially seeing that although there is significant inter-individual variation, there are actually still consistent patterns that we see among patients with chorea and among patients with dystonia. And so this suggests to us that perhaps these patterns are distinct enough or consistent enough that they might actually be able to be followed and, dare I say it, be used as a biomarker from patient to patient. So the next question we asked was, well, these LFPs are interesting. Sometimes they're higher, sometimes they're lower. Different patients will have different patterns to some extent, despite the common features we're noticing. Do these LFPs tell us anything about severity? And so this is recent data, also relatively hot off the press. But we took our first 10 patients with dystonia, divided their LFP data into left and right hemispheres, and then performed a binned analysis where we were fortunate enough to not only have local field potential data for these patients, but to also have severity data collected at the time of the clinic visit. And so this was severity data in the form of a commonly used, although imperfect, dystonia rating scale called the Burke-von Marsden. So basically, the higher score on the Burke-von Marsden, the higher the worse a person's dystonia is. And we then binned this into mild, moderate, and severe dystonia based upon prior publications using the Burke-von Marsden. And although I think that this data, it shows some degree of overlap, you can also tell that there is this quite interesting distinction between mild in green, moderate in yellow, and severe in red in both the left and the right hemispheres, really suggesting that the worse a patient's dystonia is, the worse their LFPs look, or at least the higher amplitude, the power spectral density of their LFPs is, in particular within the beta range, but not exclusively within the beta range. So we thought that this was interesting, but we sought to do a more in-depth analysis and drill down into this a bit further. Because at the end of the day, all of this work was really something that we became very interested in because of the challenge in trying to optimize treatment for these patients. Now, if we could, in fact, rely on LFPs as an indicator of the patient's dystonia severity, we realized that could, in fact, help us address those 5 limitations that I had mentioned at the beginning of the talk. So the next analysis that we did, or that Preeta did, in fact, looked at just that. And so this is a busy plot, but it's something that I think shows quite interesting data. What Preeta did was she looked in this case at the right hemisphere data is what I'm showing you. But she compared individual patients represented by each of the black diamonds. And she compared their severity of their dystonia, plotted here on the x-axis, and indicated by the Burke-von Marsden. The higher the score, the worse the dystonia. And she compared that to their LFP power, and she binned that power into each of the canonical frequency bands. And so, for example, this one in the top left is delta. She then looked at theta power, alpha power, low beta, high beta, and gamma. And what she in fact found was that there was this quite interesting linear correlation where the degree of the movement disorder severity, the worse the dystonia, the worse that the higher the magnitude of the power that seemed to correlate with that. And so higher power, stated another way, seemed to correlate with worse dystonia. And what was quite fascinating was that although the slope of this observation certainly varied somewhat from patient to patient, this was something that she found across the different frequency bands. And so looking at this data, she noticed that the correlations seemed to hold up for delta, theta, alpha, beta, which until that point we had really paid the most attention to. And even though the degree of correlation was more modest for gamma, this seemed to even hold to some extent in gamma. And this was quite interesting because as we hit the literature and we really looked back, I think it's worth mentioning that although it's not the focus of today's talk, we nevertheless in the LFP field for movement disorders have benefited a great deal from the work that's been done in adult Parkinson disease. And I think it's safe to say that we know the most about the significance and potential utility of local field potentials for adult Parkinson disease. But if we look back at some of the classic studies that had helped to establish that local field potentials can be used as a biomarker for adults with Parkinson's, what was quite interesting, and yes, these are slightly different comparisons, but you'll see here that this is the UPDRS indicating the severity of an individual's Parkinson disease on the x-axis. And here's the relative power on the y-axis. And again, that there is a difference from patient to patient, but there is in general a degree of linear correlation. And this linear correlation is in many ways reminiscent of the degree of linear correlation we're seeing for patients with dystonia. And so all that to say that we're seeing that for patients with dystonia, the higher the magnitude of their local field potentials, the more that seems to correlate with the severity of their movement disorder, their dystonia, and that does, in rough approximation, correspond very well to what's previously been observed for patients with Parkinson disease. Okay, so to go back then to some of the things that we had discussed early on, I wanted to revisit some of those 5 challenges, and I think that when we think about the fact that different patients need different bubbles, different patients need different stimulation settings, we've learned over time that placement matters, and so this is beautiful work, not by us but by Andreas Horan's group, where they've showed that for patients with dystonia, and these are largely adult patients, and this is in a different nucleus, this is largely in the subthalamic nucleus. They've mapped out electrode placements across dozens of patients and found that there are both sweet spots that can be neuroanatomically defined, as well as sour spots at which patients respond less robustly to DBS just based upon their longitudinal outcomes and their neuroanatomic placements. Horn's group has also mapped that back to different brain regions and different networks based upon brain connectivity atlases, which is quite fascinating. But I think that there are perhaps additional things that can be done, particularly in the dystonia space, and particularly for pediatric patients that have never been done before, looking at relative sweet spots of anatomic placement and relating those back not only to outcomes as mapped out here, but also to neurophysiology based upon the areas of most abnormal signal. So hopefully more to come on that in the future. This idea that benefits are often delayed days to weeks, like I said, this is something that's kind of been heuristically accepted. within the field, but we really didn't have too much objective evidence other than those couple of papers that I had shown you very briefly earlier in the talk. But as we started to record chronic sensing data using the timeline function, this is some data that we've published, just an initial observation from a single patient. But what you see here is are her local field potentials plotted over time. And what's quite interesting is that the time domain is in months. So we have here April, May, June. And what you can see is that initially the power is recorded on the y-axis. Her power spectral density in the beta range is actually quite high. Then she has this programming visit that's captured here with this thin vertical line. And you can see even at the time of the office visit, there's a substantial decrease in the power that we're seeing at the time of the visit. And so she's perhaps a little bit of the exception where we were able to see some benefit right away. And this did correlate with her clinical symptoms. What was fascinating to us, though, is that if we zoom into this, we can see that there's this drop that occurs around the time of the office visit. But as we start to look, that the power, in fact, was still present at to a high degree of magnitude, relatively speaking, even after she went back home and left the office. And so there was no further programming that was occurring. But over the next ensuing days to weeks, we started to see that even without further changes in the DBS, her power continued to drop. And it dropped until it reached a steady state, and at which we started to see that there was this gradual increase in the power, almost like there was a delayed effect from the stimulation on her neurophysiology, but that the intrinsic dystonia started to reemerge. And if we return to again, the zoomed out version of the figure, we can see that. And then at the time of the next visit, there was again a drop in the power, this time a little bit more modest, but that was something where it's almost like the dystonia needed to have successive programming visits in order to have the effect be realized. And so we're now embarking upon additional studies with additional patients to try to dive into these patterns more. I think it's also worth noticing or worth mentioning that as we've seen some of these changes over time, one of the big concerns that we've had is that it's very easy to stray into overstimulation for these patients, that we often will continue to adjust stimulation because we want to make the patient better and better. That's, I think, a natural human tendency. But nevertheless, what we found over time is that in some cases, perhaps in many cases, this may stray from that ideal stimulation outside of the sweet spot and may lead us into the realm of overstimulation. We've now seen is that for these patients, for me again, straight in front of me, we've been able to record during office visits. And this is, again, our friend Gianna, and we're trying to make further adjustments, and she's trying to hold her hand just straight out in front of her with her fingers extended, her palms still, but you can see it's not opening for her anymore. And so this is just one snapshot from the office visit.
But just hold it open like me, like this, straight out in front.
Straight out in front. She's just trying to do that. And in fact, she was able to do that. What I don't have the time to show you is she was able to do that at the beginning of the visit, but she had some dystonic activation of her fingers. As we've gone up on the stimulation, it's actually gotten worse, and she's now no longer to even sustain the hand held outstretched. And we used that data, not only for her, but for several patients to actually show using active streaming in the office that more of a good thing is not always a great thing. And so what this represents here, if I can draw your attention to the top figure, is this is a continuous session. And so this is seconds from the time that we started the active streaming. We simultaneously recorded videos, including the snapshot that I showed you just there. And then we looked at the power of the patient's local field potentials and analyzed those offline. And I think that even visually, you can see that even though there's variation, overall, the power for this particular patient tended towards increasing. And that was the opposite of what we were hoping to see. We were hoping to see that with stepwise increases in stimulation, the patient would get better and better. In this case, the opposite actually happened. We continued to stimulate the patient. During the course of the visit, we captured video that allowed us to be able to calculate Burke-von Marsden scores. And you can see the scores got worse and worse and worse until we kind of hit our point of maximal stimulation, which was 5 milliamps in this particular case. We noticed that the LFPs tended to worsen, at least visually, and then we went through a series of ramp downs, at which point we found that the patient's dystonia returned to its prior baseline. Now, when we actually looked at that quantitatively, you can see that we, in fact, have thousands of data points within this data cloud that allowed us to achieve very high levels of statistical significance when there were, in fact, differences between one epoch to another. And what this showed was that as the stimulation ramped up, we entered a time of overstimulation. So as this patient was overstimulated, the LFP's magnitude increased, worsened, if you will. The patient's dystonia worsened, and that as we then recognized that and ramped down, the power spectral density statistically significantly decreased, and the patient's dystonia decreased. Now, we didn't record the video here to show you that, but we have that for these patients here. And what you can see is a very similar phenomenon, albeit with very different patients, that as we ramped up the stimulation, we experienced a state of overstimulation that was highly statistically significant in these patients as well. And as the patients experienced clinical overstimulation, indicated by an increase or a worsening in their Burke-von Marsden scores, their LFPs worsened as well. You can see that particularly well for this third patient, that as we decreased the stimulation at the end, the LFPs improved, but also the dystonia severity scores improved. So this is, I would say, some of the first evidence for overstimulation being captured at a neurophysiologic level using local field potentials. And one of the things that we've been really keen to understand is how can local field potentials potentially help us to track responses over time. So I mentioned already that there are several difficulties in trying to determine if we're on the right track. The delays from the time we make changes in stimulation until the time that the changes in dystonia or chorea will manifest, for example. We understand that there are differences between patient to patient in terms of what they need. Finally, we know that these movement disorders fluctuate, and it can be difficult to assess responses from patient to patient. And so this is a very data-heavy slide, but let me walk you through it. What we've done is we've analyzed thousands of data points that were collected using chronic sensing. And what you see here are 10 hemispheres from 5 different patients, and each of these patients showed a clinically meaningful, defined as a greater than or equal to 7-point change in the Burke-von Marsden score from one point to another. And we simply compared the local field potential power at the time dystonia was worse, it's indicated in red, to the times where the dystonia was better, indicated in black. And what John has done in this particular analysis is he has plotted the median values, but also plotted all of the variance that you see represented by individual data points. And hopefully what you can also appreciate is that there's quite a difference if you look at this over the course of a single 24-hour day. that if each of these data points is represented at different times of day, you can see that there's quite a bit of diurnal variation that occurs for the patients. And although that pattern differs somewhat, there is definitely the potential challenge of trying to interpret if a patient comes in for one visit in the morning and then comes in the late afternoon for another visit, we might be comparing apples to oranges. But nevertheless, if you utilize this chronic sensing capability, a lot of these diurnal variations essentially will wash out. And you can see that with a high degree of statistical certainty, there's a difference between the local field potential power at the time where the patients are the more severe. You see their power is higher. At the time where their symptoms are less severe, as you can see in the black or the gray, their LFPs are in fact lower. And that this is seen consistently from patient to patient to patient, except for one outlier here at B1 that we're quite interested in digging into further. Nevertheless, I think the data is starting to accumulate that this particular modality, this chronic sensing modality, may be very valuable in assessing patients over time who are tracked using chronic sensing to follow their LFPs. So I'd like to wrap up and hopefully have a moment or two for questions. But finally, I'd like to say that most pediatric movement disorders, as we've discussed, they occur within a broader neurodevelopmental or neurodegenerative condition. Hopefully, I've given you some things to think about and hopefully made the case that LFP data is allowing us to see dystonia and chorea in a new way, or perhaps for the first time. Now that we can see it, we may be able to use this data to tell if we're starting to go off track. And this is really represented here to the right. We have a sense of what's normal and what's not in a way that we never have before. And so this work is being carried forward now through several DBS consortia that we're happy to be participating in. But again, most of the preliminary data that I've shown you, it has not been shown before and has arisen from here at Phoenix Children's. So I'm very, very grateful to our amazing team that you can see depicted here on the right. Certainly my lab and our collaborators. Always have to give a shout out to my family and the kids and the families that spur us on. So thank you very much and happy to take a question or two.
Michael, that was an amazing overview of the work you've done. There's a couple questions in the chat. I was hoping maybe you can get to them. I just want to comment for the trainees on the call. What Dr. Kruer is showing is, in my opinion, classical and prototypical physician scientist translational work. And as you guys are thinking about your careers and what you want to do with it, what Dr. Kruer is demonstrating to you is this is how you do science as a clinician. You take a clinical problem that you're passionate about, you take a piece of that clinical problem and you try to dissect it and mechanistically understand it. You look for biomarkers of disease, you look for modifiable biomarkers, and you run with it. And then you sort of manipulate that clinically to see if you can get desired outcomes. So Michael, again, phenomenal overview. I really hope that trainees look at this as a really nice example of how you can be an academic neurologist, because that's truly what you are. And I think there's some great questions in the chat box. I'll start talking.
Thanks so much, Jay. I will say that our team has grown even beyond the folks that you see pictured in the photo. We have trainees and at various stages, and so we're always there's lots of room in this type of work in particular for involvement and I think important contributions at a variety of levels if anyone listening is interested. So it looks like we have some great questions. Kevin Chapman asks, since this is a network disorder and the LFPs are identifying changes at the local level, have you looked at other network parameters that changes in stimulation settings such as fMRI and how they correlate with LFPs? I would love to. Fantastic question, and we're interested in expanding this beyond just the neurophysiologic level. We really think that using anatomic MRI and brain connectome data sets can help us to understand things better. We don't have, to my knowledge, fMRI data that's largely available for all of these patients because they were collected clinically. Some of our collaborating data sites, including Sick Kids, for example, they do have fMRI data, and so we are hoping to look at that. I think that would be very interesting, but there's the possibility of trying to expand this to include EEG, to include MEG, and other modalities. And I think that there's a lot of exciting questions that could be asked and hopefully answered. We're also very interested in trying to combine this with other molecular and cellular biomarkers using things like proteomics and even transcriptomics, and looking at the connection between local field potentials and those. Dr. Narayan asks, is there work being done on a neurostimulator that actually learns and modifies the parameters based on patient feedback? And the answer is yes and no. The work that's being done, yes, there is an adaptive or form of DBS that actually learns or at least will adjust stimulation dynamically in close to real time. Unfortunately, if you ask the patients, how are you doing? It's not such an easy question for them to answer. And so even with the help of parents, that is something where we've needed to have something more granular to go after. And in fact, some of the latest advances in technology that have now been made clinically available include the ability to adjust stimulation in near real time based on LFPs. Now it's only been unlocked for Parkinson's disease because these local field potentials have been shown to serve as informative biomarkers for Parkinson's disease. And so the FDA has approved that context of use. We're hoping that some of the work we're doing and the work that many others are doing will help unlock that potential for patients with dystonia, because we think that although there are some potentially important differences between dystonia and Parkinson's disease, that local field potentials can still be used for adaptive DBS to adjust stimulation automatically and dynamically, even in between visits for patients with dystonia. I understand we're over time, but Clary asked a great question. You showed a picture of what the DBS electrode looks like. Do you think that allowing for more sections in the electrodes could help? And so yes. So the different companies have actually leaned on or focused more on different innovations in DBS technology. Medtronic has fewer. They're the only ones that currently have the ability to record local field potentials. Some of the other companies have more capability to actually have additional levels and segments that can be activated. And so it is now possible to not just create bubbles of stimulation, but the way I like to describe it to families, to create these complex snowmen or balloon animals where stimulation can be really stacked and focused in different ways, depending upon what that particular patient needs. So I think that there are some exciting opportunities there, and also opportunities to potentially stimulate multiple different sites at once. All right, so those are all the questions in the chat. I know we're over time. I apologize. I had a lot to say, but if there are any other questions, I'm happy to take those. Otherwise, I think we can wrap. All right. Well, thanks so much, everybody. Really appreciate the fantastic discussions, and happy to continue the conversations offline. But have a great rest of your day.